Welcome, everyone. This is the IFAM seminar series, and this week the Center for Behavioral Intervention Technologies is delighted to partner with IFAM. And before we begin, please note that we'll not be monitoring the chat during the seminar. So if you do have questions, please use the Q&A function, and we'll do our best to answer them during the Q&A section. It is my distinct pleasure to introduce Dr. Edwin Boudreaux, Professor of Emergency Medicine, Psychiatry, and Population and Quantitative Health Science at UMass Chan Medical School, where he also serves as the Vice Chair of Research for the Department of Emergency Medicine. Dr. Boudreaux is a clinical health psychologist and a leader in the field of suicide prevention and intervention. He was instrumental in leading the Emergency Department Safety Assessment and Follow-up Evaluation, or the ED-SAFE study, which aimed to reduce suicide attempts among at-risk emergency department patients. He leads suicide prevention implementation projects, such as the UMass Zero Suicide Framework implementation, and he co-directs the Center for Accelerating Practice to End Suicide, or CAPES, which focuses on translating empirically supported technologies into clinical practice to reduce suicide rates across healthcare settings. His pioneering work in emergency department and healthcare centers has been recognized by groups such as the American Foundation for Suicide Prevention, and today we're honored to have him here to share his expertise with us. Please join me in welcoming Dr. Ed Boudreaux.
Thank you so much. It's a real pleasure to be here. I've always been a fan of David's work and the CBIT's work. It's been instrumental in my career development, so it's a real pleasure and an honor to be here to talk with you today. We're going to talk about Jaspr Health. I'm going to dive in, but Jaspr Health is a digital health suicide prevention tool that's designed for use in the emergency departments. I wanted to thank Linda Dept, who is the founder and CEO of Evidence-Based Practice Institute. It's Evidence-Based Practice Institute that has designed and hosts and has commercialized the Jaspr program. Topher Jerome, who is a person with lived experience who has been instrumental in creating some of the content that I'm going to present to you today. And then Bashir Ramon, who also helped with the content. He's a senior operations officer of CAPES, our center. The disclosure, the materials I'm going to present are funded by the National Institute of Mental Health. The other notable disclosure is that about 7 years ago, I worked with Linda Dept and the Jaspr Health team as a consultant, advising them on emergency department clinical workflow because they wanted to make sure that they understood the clinical workflow so they could understand how to best position Jaspr. It's been a while since I've done that. That was 7 years, but I did make less than $5,000 in consulting for that work. Learning objectives: to understand the development and evidence-based content of Jaspr Health software, to improve knowledge and skill related to deploying suicide-related digital health interventions in the emergency department and by extension other healthcare settings, and to anticipate and be prepared to address impediments to deploying digital health interventions in the emergency department and other healthcare settings. So the reason why I am such a fan of Jaspr and why we decided to study Jaspr as our signature project in our P50 Center application is because I think Jaspr Health did an exemplar job at embracing design thinking or user-centered design. You can see here the different components that went into this. Emergency department clinical workflow and electronic health record integration were basically built in from the very beginning. From the earliest sketches of what Jaspr would look like, they were really thinking about what workflow would look like and how they were going to get it integrated into the electronic health record. Because if any of you are clinicians, you know that if it doesn't happen in the EHR, it doesn't happen. People, clinicians are not gonna search for some sort of external program or external platform. It really needs to be integrated into the workflow and to the EHR. They interviewed clinicians, people who were actually working in emergency departments. They interviewed people with lived experience, so people who actually were suicidal, who had been treated in an emergency department. Like Topher Jerome, he's one of their panelists who focused on representing the lived experience. And then suicide prevention experts, of course. So they really took this multi-dimensional approach, and they really embraced design thinking from the very beginning. And all of these people were basically empaneled to provide guidance at every step of the development. And it shows in the product output, which is why I was so impressed, because it's not only rooted in the best evidence, but it's also very intuitive and satisfying for people to use. So I'm going to start with a story about what life is like in an emergency department for a person who is suicidal. That's the top row. So if you look all the way to the left, what typically happens is the patient comes in, they're identified at risk, probably through screening at triage. The patient is left alone without resources while waiting for care. This is pretty common because emergency departments don't really have the mindset that they should be initiating interventions for suicide risk from the beginning. If you come in with the ST elevated MI, so you come in with a cardiac presentation and they hook you up to EKG and they know you have a STEMI, you're going to get intervention immediately. Time is muscle. That's the philosophy. But it's very, very different for behavioral health complaints, including suicide. The person is going to be left alone usually, or if they're not left alone, they're left with a sitter, which we prefer the term observers, but sitters are often the term that people are using, where a person is sitting there watching the person to make sure they don't try to hurt themselves in the setting. They stay in high distress. They ruminate on the problem. What else do they have to do? Because what we have to do often is put them in a safe room where there is no ligature points. So if you've never seen a safe room, you should look it up because it looks like a prison cell. So a person is in the very austere conditions. Their clothing is usually removed. Their personal belongings are removed. They're not allowed access to their phones or any other personal digital devices. And their visitors are usually restricted. Can you imagine a worst possible scenario for someone who is struggling with a mental health crisis and who is suicidal? But that's exactly what we put them through each and every day. This is a very common occurrence. It probably happens right down the road in your emergency department here. And then a behavioral health provider, after the person is typically waited there for hours or sometimes days, people will wait in the emergency departments for days before they see a behavioral health provider. That person comes in, conducts an assessment, and that assessment is designed to basically decide whether the person is going to be admitted to an inpatient psychiatric facility or if they're going to be discharged home. So that assessment is actually also not a therapeutic assessment. It doesn't guide therapy, doesn't guide intervention. It's a triage decision-making process. So this person has come in seeking help, and they haven't gotten help at all throughout this entire process. Instead, what they've gotten is waiting and usually being ignored by most of the other clinicians. And then finally, when the behavioral health person comes in, they're there to make a decision. They're not there to actually help the patient while they're there. So this is a well-known in the field. It's what I've worked most of my career to solve, is to try to change that paradigm, to try to change the quality of the care people are getting whenever they're identified as suicidal. And what Jaspr does is Jaspr allows the person to start receiving evidence-based suicide care immediately upon being given the tablet. So Jaspr is delivered to the patient on a tablet PC, and that tablet PC, we'll talk more about what the specific modules are, but it has both assessment and intervention components. So the person, while they're waiting for their care, can engage with Jaspr for as long as they want. So this is not just a therapeutic exercise, it's also a distraction. They now have access to something that can keep their mind occupied, that can keep them engaged instead of just sitting literally and looking at the four walls or looking at their sitter who's looking at them. So these are the components that are included in Jaspr. It conducts a comprehensive suicide risk assessment that is patterned after the comprehensive, the collaborative assessment and management of suicide, CAMS. So you may have heard about CAMS. CAMS is one of the most evidence-based approaches for managing suicide risk. It's got dozens of randomized trials, so it's really firmly established in the suicide prevention field. So what the Jaspr Health team did is they took that content that was there, that's basically on paper, and that was basically part of the clinical assessment, and they figured out how to create a chatbot style assessment that guides the patient through the assessment themselves. And they did that, they co-designed that chatbot with people with lived experience. So rather than sounding and seeming like a computer, it actually has a much more natural and humanistic flow. It's not AI, so it's not artificial intelligence, and there's not another person on the other side. It's basically just very well-developed branching algorithms with cues that help the person and guide them through the whole process of completing the suicide risk assessment and creating a personalized safety plan. So in the field of suicide prevention, one of the best practices that has emerged over the past 5, maybe 10 years is personalized or collaborative safety planning, where you work with the patient to develop a safety plan for them to be able to follow specific steps. It's a coping tool for whenever they're experiencing a high-risk situation, a crisis, or they're experiencing some triggers. So there are multiple ways to do the safety plan, but Greg Brown and Barbara Stanley produced the safety plan intervention, which is the one that's probably gotten the most traction. So Jaspr, you can either do the Stanley Brown safety plan, so the SPI, a site can choose that one, or they can choose the crisis response plan from CAMS, because CAMS also has a type of safety planning called crisis response planning. So you could have either option. The site would choose which one they want based off of the training and the protocols that are present at that site. It also conducts a lethal means assessment and counseling. So it helps to walk through the person in terms of identifying their access to lethal means and coming up with a plan to put space and time between the person and their access to their lethal means. So if you know anything about suicide prevention, access to lethal means is one of the bread and butter mainstays of what we try to accomplish when we're working with someone with suicide. Because if you can simply prevent them from having access to lethal means, then that helps to keep them alive for another day. And what we know about suicide risk is that it often ebbs and flows. And so if you can prevent the person from acting, often that suicide risk will ebb. It doesn't always go down to zero, but it'll ebb on its own. So this idea of putting space and time between the person and access to their lethal means is really, really important. Jaspr helps to do that. It also provides access to behavioral coping skills. So there's an entire portfolio of distraction activities and coping skills like measured breathing. There's videos with puppies, which is a real popular video. So all of these coping and distraction tasks people can access through the comfort and skills section. And finally, it reduces stigma and it instills hope and connection, because in addition to these behavioral tasks that have been really designed based off of DBT, dialectical and behavioral therapy, it also has a whole library of people with lived experience who are telling their own stories in their own voice about their own struggle with suicide and how they have been able to overcome it or how they manage it. So these stories are designed to instill hope and to give people practical recommendations for what worked for them. And the person can choose which videos are that they want to see. The videos have a little caption, a little description about what they talk about, so people know what the content is. So this is an example of what I was talking about with the comfort and coping skills. So you can see to the right here, there's these little tiles, and a person can click on the tile, can look at it, can figure out what the coping strategy or the distraction is about, and then they can choose to engage in that activity. They're all designed to be very, very short for a couple of reasons. Anyone who is in an emergency department, has ever been in an emergency department, knows that it's chaotic, it's difficult to concentrate, and if you have a psychiatric condition, often that comes with problems with processing anyway, right? So all of these are designed to be really small, very focused, bite-sized experiences to be able to match the attention span a person is likely to have if they're in crisis in an emergency department. The shared stories I mentioned earlier, so some of the examples you see listed here are the topics that would appear beneath the photograph of the actual person. So these are not actors, these are real people who are telling their own stories. And all of the tools that the person engages with on the tablet can actually be taken with them on an app that they download, and that the tablet has a way of connecting the person's downloaded application with a code, so that when they leave, they actually have the app on their phone and they have access to all of the content, including their digital safety plan, the safety plan that they built while they were in the ED. So if you think about what happens ordinarily in an emergency department for a person who is suicidal and discharged, often, not always, but often if they're discharged, they're discharged with less than optimal resources. The less than optimal resources is usually something that's going to be printed out of the electronic health record, and maybe a list of providers that might be in the community. And often that's all people get. If they actually have a provider identified and an appointment scheduled, that would be a pretty high bar. That often doesn't happen. That would be the best that the person would get. If they engage in Jaspr, they have all of this additional content that they never would have received that they can continue to engage with over time. Now, what do the providers get? So what's the value to the providers? It should be pretty apparent what the value is to the patient so far. They're getting a lot of content that's evidence-based, that's delivered in a very attractive and appealing way that they ordinarily wouldn't be getting in the ED or after. But what do the providers get? Well, because the conversational guide, the avatar, the chatbot assesses the person's suicide risk, if you can deploy Jaspr before the mental health professional actually goes in to assess the patient, then that mental health professional can have access to this assessment before they even see the patient. So basically, it's almost like a psych tech going and getting some information from the patient before the behavioral health person actually even comes in. So it can make the behavioral health clinician more effective and efficient because they can focus in on some problematic areas. So for example, there are ratings of different suicide drivers. In CAMS, we talk often about suicide drivers. These are the things that are driving the person's suicide risk. And it does an assessment of those things, and it has a very easy Likert scale from 0 to 5 that shows how problematic these main suicide drivers are for that individual. And so the behavioral health clinician who's reading this report, which comes into the electronic health record automatically because it's integrated. Remember what I talked about earlier. So when the patient is finished with that assessment, that report comes into, we use Epic, and that's the biggest deployment is through Epic, but they've done it in other EHRs too. But the reports come in for the clinicians and the treatment team to be able to review these reports. There's 2 reports. There's a risk assessment, and then there's a safety plan. So the safety plan doesn't have to be built from scratch with the individual. Actually, what they can do, the clinician can review the safety plan, can actually use that in 2 ways. One way, they can use it to determine as part of their criterion for triaging the patient. So if you think about it, if you have a patient who's going to be engaged in Jaspr and is going to develop a safety plan, and that safety plan looks really good, you have a higher confidence that this person actually can be discharged instead of admitted because they did a good job with safety planning, because that's part of the decision making when you're deciding whether or not a person needs to be admitted. Are they going to be able to stay safe at home? And if they can't do a safety plan because they don't want to engage in it, or their safety plan is really bad, then you would want to evaluate whether that person really should be sent home. But if they have a really great safety plan, then that can help provide information and assessment for your decision making as to whether or not the person should stay in the ED, get admitted or get discharged. But also, because like I mentioned earlier, safety planning is now a best practice. We really are expecting safety plans to be built with most patients who have suicide risk who are going to be discharged from the emergency department. So that it already builds the safety plan. Now, the clinician should read it and make sure that the safety plan is a good one. And if there are any questions, they can go and talk with the patient. And to do that, you can get into the clinician view of the safety plan on the tablet. So the patient already did the self-report version, but if you want to go and talk with the patient, you pick up the tablet and you can get into a clinician view, which is basically like an interview. It bypasses the whole chatbot interface. That way you can go and you can talk with the patient, you can update the safety plan, and then when that happens, 2 things happen. It updates the safety plan in Jaspr, so the patient gets the updated safety plan on their phone, and it also sends a new note with the updated safety plan into Epic. So you always have the alignment between what's being presented in Epic and what's in the safety plan in the Jaspr app, which is a real nice feature. So the 2 reports come in that actually help with the clinical assessment and with delivering the intervention for the clinicians. This is important because it's a selling point, right? If you can show value to clinicians and they like the information they're getting, and you can task shift some of the stuff that's already expected to happen from the clinician's point of view, then now you're providing value. You're not only providing interventions that the patient might not have ever received, but you're doing it in a way that doesn't add a lot of increased burden to the clinicians. These are some examples of the kinds of content from the people with lived experience. They informed every aspect, but especially the messages for the coping skills and for the people with lived experience stories. This is an example of what the therapeutic content looks like. You can see this is just a snippet. There's usually a profile for the individual with a little summary of what the story is about. And this is what Jaspr at home looks like on their phone. So it's for Android and for Apple. So you can see it's got the content. It has big areas that the person can choose. Like if they want to look at their safety plan, they can go to the safety planning section. Or if they want to do confidence skills or look at videos, they can click to those main menus. All right. So that, in a nutshell, is what the application looks like and how it was developed and the content that it provides. I'm going to go on and talk a little bit about the evidence. But before I do that, are there any questions about what the application actually does? Yes.
Messaging the patient about she's going to see, because I know my phone is spying on me, and how concerned my patients be that they're sort of giving something away, or they're really talking with them.
That's a very prescient question. One of the very first issues we had with the randomized trial we're doing right now with like subject, with number 5, like really early on, was the research coordinator who was introducing the study to the patient didn't emphasize that there was not another person on the other side, that the chatbot wasn't texting. They weren't texting another person. So especially with patients who have psychiatric illness and who might have some paranoia, it's really, really important to provide the context for what's happening to make sure the person doesn't think there's someone else on the other side of the chatbot. And you can actually, I didn't mention this, I should have. Jaspr is designed to be flexible so that you have these modules and you can click off of them if you don't want to administer it. So for people who might have difficulty with the chatbot or might be suspicious, you can just choose the comfort and skills, in which case there's no input by the patient. They just go to the videos and they can access all the videos and all the other content without having to actually enter anything personal about themselves. So in part, Jaspr designed it that way because of people saying that they were going to be concerned that if they're providing information, they may be providing it to someone who's going to do something nefarious with that information. Yeah, the clinician is, right. The clinician is entering it. So when the engagement is described to the patient, that's described, that they're going to go through, if the clinician judges that the assessment and the safety plan is something that this person is appropriate for this person, they will have that conversation with the patient and explain to them, there's no one on the other side, it's just the computer, it's going to walk you through, you're going to provide answers, and then it's going to summarize those answers for us so that we can do a better job treating you. We want to know this information, and we want to be able to provide you better care, and this will help us to do that while we're seeing other patients. You can do this right now, and that way, when we are able to get to you, we'll have more information, and it'll be better care, faster care for you. So basically, you describe to them the value proposition to the patient. It's not appropriate for all patients. So patients who are combative, patients who are intoxicated, so there's some obvious, very practical clinical criterion for deciding whether or not the person should be given the tablet. And most of those will revolve around whether or not the patient is cognitively and emotionally and physically capable of doing it, because they do have to hold the tablet. So those are the primary, exclusion criterion for whether or not the person can engage with it. All right, let's talk about some of the evidence. So the randomized controlled trial that was supposed to be the big study that demonstrated Jaspr versus care as usual was interrupted by COVID. You guys remember that? COVID? It's almost like it's just a bad dream, right? But it definitely impacted all of our studies. I bet it impacted the studies that were being done here, and Jaspr was one of the main casualties because you couldn't even approach patients. And so the grant basically ran out and they only had a very small sample size. But this is what they found with that small sample size. When you looked at whether or not the person received, they used the crisis stabilization plan instead of the SPI, the Stanley Brown. So they used the crisis stabilization plan, which is from CAMS. 100% of the people who were enrolled into the Jaspr condition received basically a safety plan versus only 12% of the care as usual. So already you're seeing that people are getting an engagement with an intervention that they ordinarily would not be getting. Same thing was true for lethal means counseling. 85% of the Jaspr condition developed a lethal means safety plan versus 6% as care as usual. 93% said that they had received healthy messages of hope and coping from people with lived experience. And of course, a very small percentage of those in care as usual, because there's no one, if you didn't get the Jaspr app, there's no one who has lived experience who's running around the emergency department talking with people in most EDs. You do have peer support in some EDs where there will be people with lived experience, but most EDs don't have that. And then coping skills, 93% showed that they had learned coping skills to cope with future suicidal urges compared to 12% of the care as usual. So if you think about this as a process or a mediation or a moderator outcome, like what is it that Jaspr is providing that could impact outcomes? We basically showed that we're engaging the target, the intervention targets in the NIMH way of thinking about these things. These are the things that we are thinking would actually impact outcomes. They didn't look at outcomes because, like I said, the study was truncated because of COVID. This is also really important for the emergency department staff. So making a value proposition to get an emergency department to want to adopt this, you really have to show that there's value for the ED itself, for the system, not just the patients and the clinicians. And this is one of the most important value propositions. So they measured distress and agitation before, like when they first enrolled the person, and then after the person had been in treatment or in the ED for a while. So they did a pre-post, and what you see is that Jaspr leads to a statistically significant distress ratings during the visit, as well as decreased agitation ratings. So in other words, the clinical impact actually happens during the ED visit, which is something really important, because if you can keep people who have very long visits, who have psychiatric illness, if you can keep their distress and their agitation low, that helps everyone in the emergency department. Because the opposite of that is escalation. And when a patient escalates in the emergency department, it causes all kinds of mayhem. And lately, especially because of the problems with violence in emergency departments, what it does first is lead to a show of force. I don't know if you guys ever have heard this term, but it's a show of force, meaning you start to escalate and they get the security guards and other usually large males to come into the room and basically say, if you continue to escalate, we're going to have to restrain you. Of course, what does that do? Usually it's pretty traumatic for the patient, and it actually ends up causing them to escalate, because who wants to be threatened when you're in a healthcare system? So if you can reduce those types of interactions and reduce the need for restraints, then that is a huge value for the system. Another naturalistic study was performed with about 988 total subjects. It was a real-world study. It was not a randomized clinical trial. They basically compared people who had similar characteristics who received Jaspr to people who didn't receive Jaspr. So the baseline factors were controlled for. See, actually, the Jaspr patients had a higher rate of discharge from the emergency department, which is also another value for the patient and for the system. Because as you guys know, there's a huge access problem right now in most of the country. It's very difficult to get people into inpatient care. So if you can provide outpatient care instead, then you're helping with the access problem. The Joint Commission, which I'm assuming most of you know about, but if you don't, the Joint Commission is an organization that accredits healthcare systems like hospitals like Northwestern. And they have a lot of power. And they determine the standards of care that hospitals have to follow in a bunch of different areas, including suicide prevention. Suicide is a zero event. Center for Medicare and Medicaid Services and the Joint Commission consider this a zero event. In other words, no suicide should ever happen when the person is under your care. So by the time they enter the ED or inpatient unit to the time they leave, really there's expectation that a person doesn't kill themselves. It's obviously a logical thing. And so Joint Commission creates these standards, and Joint Commission has recommended safety planning. They haven't required it, not yet, but they've recommended safety planning. So you can see here that the 76% in the Jaspr versus 39% in the care as usual is important because it's another value proposition. When we're talking about implementation, you're thinking about what's the value to the system? Why would they want to implement it? This is the reason why they want to implement it, because it can help them with complying with the Joint Commission's expectations, which health systems are motivated to do. Look at this, a reduced restraint use. Remember when I talked about where you've got this show of force, you go in there to try to de-escalate a patient and you have this iatrogenic effect that actually ends up escalating the patient? Well, Jaspr was associated with lower restraint use and it reduced agitation and distress, similar to what I showed earlier. So similarly, another naturalistic control study in 2 large healthcare systems were really focused around determining whether there were adverse events. Because as harmless as this sounds, a big part of the challenge with getting health systems to embrace something new like this is they're worried about risk. They're worried about what is something new introduced in terms of the medical legal risk and adverse events that could happen if a person is doing something new. So part of this study was designed because they were submitting Jaspr to the FDA, they knew they needed this safety data. So is Jaspr safe? Yes, there were no adverse events reported in almost 1,000 patients. The most commonly assigned modules were the comfort and skills. So that's those videos and trainings on coping skills and the lethal means assessment. They found that Jaspr helped to stabilize a suicide crisis because they found yet again that Jaspr reduced agitation and distress. So there's multiple data points in different health systems showing that when a person engages with Jaspr, the agitation and distress decreases over time rather than staying the same or increasing. And did patients like Jaspr? Yes, a majority recommended the app, 84% in one of the systems and 89% in the other. So this study is really, I think, interesting because I think it has analogs in a lot of digital health. So I know a lot of you are interested in digital health. A strategy that we've used in digital health development is to come up with key performance elements that represent evidence-based practices. So usually a group of experts comes together and says, okay, if we're going to treat some kind of target condition like suicide, these are the things that we can confidently say are based in strong evidence. So you come up with a list of those key performance elements for evidence-based care. Usually use a rigorous model, a Delphi model or something like that to come up with that list. And then you use it and you apply it to applications. Do these applications meet these evidence-based criteria? So that's what they did for Jaspr. So this is a dense slide. I can sum it down in study number 2. There's basically of the key performance elements that were determined by experts to be number 1, important, and number 2, applicable in a digital health context, because not all KPEs are actually applicable to a digital health context. So of the KPEs identified, Jaspr basically covered 93 to 96% of those KPEs that a digital health tool could have contained. So this is basically like a content analysis. So we have the other studies that are looking at what's happening when a person uses it. This is a content analysis of the content that helps to reinforce that this is delivering evidence-based care. And then patient satisfaction, I mentioned this earlier. This is really important. I have some quotes up here. Basically, when we ask patients what their experiences are, most of them are very satisfied with it. Not all of them, but most of them are satisfied with it and they recommend the application to other people. So that was the existing data out there on Jaspr. That's like actually the corpus of published data on Jaspr. So really not that much, right? If you think about it, the way we think about evidence-based practices, that's really not that much. So we proposed as part of our center application, as part of our center grant to do a randomized controlled trial and an implementation study side by side. So we have a randomized individual level trial of Jaspr at UMass, where I work. And then we have full implementation trials at Ohio State University Medical Center, 2 EDs there, and the University of Colorado, 2 EDs there. So we're doing them in parallel rather than sequential to be able to accelerate the the time it takes to be able to really understand what's going on with Jaspr and how to implement it effectively. So I'm going to kind of blaze through this a little bit because I see I have only 15 minutes left, and I want to make sure I save some time to be able to answer questions. So let's talk first about something that you guys are probably interested in. And the reason why I chose these implementation barriers is because I think these implementation barriers actually apply to any digital health tool that you're trying to implement in a healthcare setting, acute care setting especially, and it really doesn't matter what the target is. These are generalizable issues that I think you're going to face, especially if your tool is designed to have a patient-facing component and a clinician-facing component and to operate within a clinical milieu. So those are the conditions that I think these are relevant to. So Jaspr has to be integrated into a site's electronic health record because the clinicians treating the patient have to see the reports that are generated, and they're not going to go to the tablet and look at it on the tablet or click out of Epic and go look at it, on some other screen. They're just not going to do it. So fundamental, and this is part of the consulting that I was paid for, is to basically impress upon the Jaspr team that they couldn't go forward with a live commercial version that wasn't integrated into Epic, especially Epic, because Epic's the dominant player in academic medical settings. Academic medical settings are primarily the primary customer because they're the ones who are going to buy this product. So they developed the integration, and that's a barrier to get it integrated. If anyone, I see a lot of nodding heads, like you guys probably know, like to get something integrated into an electronic health record at a site is costly. It takes time. And so what can you do about that? Well, actually, some EHRs like Epic kind of have like an app orchard. They have a way to be able to register your application with them and to write it in such a way, including to design the software technology backend, but also to design the technical specifications to help a site so that you get a jump up on it. It's not exactly plug and play, but that's the mentality is if you design it right, it makes this easier. And Jaspr did that really well. So I've done EHR integration stuff for 15 years now. Jaspr took 3 months to integrate from start to finish. So all my other applications have taken years for less integration. So 3 months might sound like a long time, but once they started on the integration to the point at which we were actually able to deploy live in Epic was 3 months. So that's amazing. That's blazingly fast. So this is helping to reduce that friction of implementation by making it easy and cost effective to integrate into the health system because you're now plugged into their EHR. I think that's a real important implementation principle to think about whenever you're designing digital health solutions that are under this context that I described earlier. The other thing that you can do, so one of the things that people were concerned about, and this is a legitimate concern, is that the patient would engage in Jaspr. They put all kinds of information about their suicide risk in this application. This application is going to send these notes to Epic, and now they're going to be in the patient's electronic health record. So first off, that is a huge paradigm shift for an emergency department. They don't get any patient-reported measures. So already you're asking them to wrap their heads around getting patient information sent straight to the chart. It's not like a PHQ-9 or a GAD-7 or a medical history form that outpatient providers are used to seeing and are used to getting electronically, usually through the patient portal. This is very different. It doesn't come in through the patient portal, first off. It comes in and the notes get sent to the notes section where all the other notes are. So the clinicians have their notes there and Jaspr has a note there. What if they missed that note? What if patient engaged in Jaspr? Now, bear in mind that the people we're talking about are already identified clinically as being suicidal. That's important. So it's not like we're just giving this to everybody and they're suddenly talking about their suicide risk and no one knows what's happening. No, these are people who are already identified as suicidal. So most of the risk associated with this kind of practice is already mitigated by the fact that the clinician is choosing to be able to administer the Jaspr application. But nevertheless, the reports could come in, and what happens if they come in and no one sees them? And we discharge a patient and they have all of this really high risk that's associated with their self-report that contradicts what the clinical assessment says. So that's a real concern. You don't want that kind of disagreement, although as a proviso, I see some emergency physicians here. This kind of thing happens all the time in the emergency department for almost every presenting complaint, that you will get different pictures over the course. Some says this level, some says this level. So it's common in emergency medicine, period. But what you don't want is a patient reported facing report in there contradicting what the clinicians say, and the clinicians haven't addressed it. So how do you do that? Well, in the electronic health record, you can design cues to be able to make sure, and processes and procedures to make sure that those notes are seen and acknowledged by the clinicians. So that's what we did at UMass to make sure that the person couldn't be discharged without the clinicians knowing that there was a report to be seen. So that's the other value of the EHR integration, because if it's outside of the EHR, you can't do that. So this pulls the work and the cues for action, or nudges. You guys are, I'm sure, quite familiar with that. Nudges or cues to action. It pulls it into the normal working space that the clinicians know and use on an everyday basis. I think this is essential for effective digital health that is going to use both patient and clinician-facing parts. So you create easy buttons, too, that help you, okay, there's a track board. So you can think of a track board in the emergency department as patients in rows and information in columns. And it's an organizing heuristic that all clinicians use to be able to figure out what they have to do, when results are in, and stuff like that. So the track board, every ED clinician knows. Well, we added a column to that track board that they could wrench in that has the Jaspr and has a little J next to the patient's name if there's a report for them to see. And they click on that and it brings them straight to the report. So they can go straight from the track board, not have to open up the patient's chart. And it pulls up the patient's chart automatically and brings them to the reports. So that's another real satisfier, because if you make the workflow easier, clinicians are more likely to adopt it.
Thank you very much, Dr. Boudreaux.
Welcome.
This was a wonderful presentation, and I think we're at time now, so we have to wrap up and give the room to another group. But this was wonderful. Thank you so much.
Welcome. It's a pleasure.